Hi everyone. I thank the organizers for inviting me to talk on this SciOp conference. And the topic of my talk is when to transplant ALL and AML. I was hoping to go to Mumbai. I was actually ready to go to Mumbai last year, but obviously with the COVID, we cannot go anywhere. So we have to just do it with the online webinars. So my topic today is when to transplant pediatric ALL and AML. I have slightly changed the topic, and I think I'm going to talk about indications of stem cell transplantation in pediatric ALL, AML, and tell you know when not to transplant. Outline of the talk, I want to discuss about this way, interesting cases. I'm going to tell you, or 4 interesting cases I've come across in the last 8 years in Singapore, and whether you recommend a stem cell transplant. What are the current indications of stem cell transplant in ALL and AML in pediatrics? What are the factors which influence the decision whether to go for a transplant or not? And then I'll do a follow-up of the interesting 4 cases I will describe first. And one slide about the immunological intervention in leukemia and how that changes the discussion about transplant and the logistics of transplants. And then one summary slide, and hopefully I can finish within 15 minutes. So some interesting cases, and you just think within yourself whether you recommend a SCT. I cannot do a Zoom poll, unfortunately. So first one is an infant ALL, 4-month-old baby girl who presented the pre-ALL, a high white cell count of 250,000. And her CNS was a traumatic tap, but there was no blast on the second sample. Cytogenetics came as a KMT2A negative. So she was MLL negative, and she had a reasonable response to the 3-drug induction, which we use in MAS4 protocol. Currently in Singapore, which is 0.08%. Question is, would you recommend a stem cell transplant in CR1 for this infant with a high white cell count only at 4 months of age? While you're thinking about that, the next child I'm going to tell you is a pre-ALL 4-year-old girl who was NCI standard risk, treated on 3-drug induction, and the cytogenetics came as low hypodiploidy. And she was actually near haploidy. And MRD at day 33 was intermediate risk. So question is, would you recommend stem cell transplant in CR1? Third one was a 10-year-old girl who was a pre-ALL, low white cell count, cytogenetics, there was no adverse features, but she had a IKZF1 deletion detected, and she was treated with 3-drug induction, which we use in our current Singapore protocol. And day 33 bone marrow showed that she was not in remission. She had 10% blast cells. So question is, would you recommend a CT in CR1? And fourth is a AML kid, 8-month-old, who was never seen or referred to me from Dubai. She was diagnosed in Dubai with AML, M4, M5 morphology, CNS negative, white cell count was raised. And she, in cytogenetics, had a peculiar KMT2A regimen of translocation 1113. She was treated on the BFM 2004 protocol, and her MRD was 0.08% by flow after cycle 1. And she had a matched sibling, so she referred to me for a sibling transplant. Question is whether it's indicated or not. So while you're thinking about these 4 cases, let's just go to the current usually practiced indications for stem cell transplant in ALL first. And I've taken it from a paper 3 years ago, the current North American indications for first transplant in pediatric ALL. On the left-hand side is the status, which is CR1, usually hypodiploid ALL, primary induction failure, slow responders with persistent MRD, usually after first 12 weeks of chemotherapy. Will you consider that they probably should go for a transplant? In CR2, relapsed ALLs, early relapses are always bad, or any T-cell or pH-positive ALL relapse are bad. Late relapse, if they respond and become MRD negative end of induction, Vasquez-Hazard 3 protocol showed that they can 70% can be salvaged just with chemotherapy, but MRD positive will need a transplant. And CR3, obviously, any patients will need a transplant. So these are indications based on all the COG protocols. What about the European group? This BFM EOP ALL 2009 study protocol is a bit old structure, but it sort of showed on the left side the risk factors like no CR, 411 translocation, hypodiploidy, poor predictional response. They combine that with the PCR MRD report results, and then with whatever donors are available, is a matched donor or mismatched donor. And then they come out with this algorithm who should be transplanted in CR1 or who shouldn't. Now, 10 years down the line, obviously donor difference is not much in pediatric leukemia, so this doesn't hold properly. So with that background, I go to the three cases I have described in the beginning, and what is the current indications for this. So the infant ALL kit, the Japanese group recently published last year about their MLL10 trial, and they stratified all the infant ALLs into low risk if they're KMT2A germline mutation, high risk if they're KMT2A rearranged, and less than 6 months of CNS positive. And obviously MRD was also monitored, and they offered stem cell transplant to all the high risk group babies. Question is, did it make a difference? So KMT2A rearrangement came as a very poor prognostic feature, and also the high risk group remained poor despite the stem cell transplant, only about 56% long-term survival. And they showed that the MRD high risk group, so at time point 3, if they remain still positive, and their outcomes are abysmal, only about 10% 3-year and 5-year survival, which goes in hand with the interferon trial as well. And transplant actually didn't make much difference to this high risk group. What about the second child I showed about hypodiploid ALL? Do they benefit from stem cell transplant? So this is a paper from JCO in 2019, the COG group article, which showed that hypodiploid ALL, all patients, including the high risk, they have a very poor outcome, almost less than 50% event-free and overall survival. But transplant, does it make any difference? So in the overall group, whether they had chemotherapy or stem cell transplant, it actually did not make any difference. And did it make a difference in the standard risk group? No. In the high risk group of hypodiploidy, also no. There's no benefit of stem cell transplant in this group. So they came up with this idea that hematopoietic stem cell transplant does not improve poor outcome in children with hypodiploid ALL. So we need better treatment strategy to improve outcome in this hypodiploid ALL group, and transplant is not the answer. About the third child I've described who had a IKZF1 deletion. So this paper from Martin Standuller's group, which showed the German group in the left and the Italian cohort on the right, which showed that Icaros plus, which is Icaros deletion plus CDKN2A, 2B, PAX5 or PAR1, they have a very poor prognostic profile because their event-free survival are very poor. And the reason for that is a very high risk of relapse. So they're both cohort, German and Italian cohort, it was almost 50%. So this group certainly will benefit from intensification, which should be a transplant. And there are a few other molecular subgroups which have got a very high risk of relapse. If you look at Charles Mulligan's St. Jude's paper, they would have some very few very high risk molecular subgroups which will need a stem cell transplant. What about the acute myeloid leukemia transplant? Current indications, it's a bit easier. Any AML patient who has relapsed or refractory to the frontline therapy or a high risk group should have a consolidation with the transplant. The problem is the high risk group identification. How do you identify them? The white cell count, age, FAB classification has limited influence. Cytogenetics is increasing consensus among the groups. And flow cytometry, although not as good as ALL, but a discriminatory level is probably 1.1%, and after course 2, which defines a very high risk group, and they probably need a transplant for improvement in the outcome. All these individual groups have slightly different cytogenetic subgroups, but basically monosomal karyotype or inversions 3 or FLT3, they're usually high risk. Combined with the persistent MRD of more than 0.1% after time point 2 is probably indication for transplant. When the MyChild-01 results come, we'll be a bit more clear about it. What are the factors which influence the decision for stem cell transplant? So there are a few major stem cell transplant issues we have to consider. So whenever I'm referred a patient for transplant, I advise transplant, I always think of there should not be any transplant mortality, which is currently at about 5% in big groups. No graft failure, which is very rare, less than 5%. There should not be grade 3 or 4 GVHD, which is still in the SGT 2003 trial was about 13% in matched sibling cohort. So not a minor issue. No relapse. Unfortunately, still 25% patients, even after transplant, would relapse. And then what we always tend to forget is that there should not be any major long-term side effects. So the other factors which we also need to consider is what is the cost, financial cost. Transplant is not cheap, and many patients cannot provide for the transplant. And then we have to think about what are the long-term side effects. Knowing that ALL transplant from the Forum trial, you need to give TBI. What are the long-term consequences of TBI to the small children that we need to consider? Donor availability has become less of an issue now with the haplo transplant cohort. But I would mention to you the center effect. It's very important to consider what is a good center for transplant. And this paper from Thomas Lingerby in Blood in 2010, which looked at the European cohort of haploidentical transplant in high-risk ALL. And they clearly showed those centers were doing a lot of transplant. They had better leukemia-free survival compared to those who are doing less transplants. So this is something which you must consider. So the interesting cases follow-up. I go to the infant ALL kid. It was a KMT2A negative. This baby, we just continued with intermediate risk chemotherapy, and she remains in remission 4 years on. And although she was 4 months, high white cell count, but she didn't need a transplant. She was cured by chemotherapy. The second one was the low hypodiploidy, near haploidy kid. We actually advised a stem cell transplant, and she had a mud transplant CR1. But she relapsed after 8 months and died from the relapse. So we actually did not make a difference, which goes with the COG trial finding as well. Third case was the 10-year-old girl who came with a IKZF1 deletion, and she was induction failure. She had 10% blast at day 33. So yes, you would transplant this sort of patients, but she had a catastrophic CNS hemorrhage at about that time and had a major neurodeficit. So she was not fit for transplant. So we just continued intermediate risk chemotherapy. And she remained in remission 4 years on. Later on, we found out that she had a DUX4 mutation as well. So this Icarus plus group, if they have a ERG deletion with the DUX4 mutation, they actually do very well. So this just shows that the cytogenetic and molecular subgroups are very important in identifying, in making a decision. The lastly was this AML kid, 8-month-old, who had a strange MLL mutation, 1113. According to the BFM protocol, yes, she should have had a transplant CR1, but then I had to consult Brenda Gibson, Dirk Reinhardt, Hiroto Inaba, and all of them. They suggested in the newer protocols, this is not an indication. So despite having a full match sibling, I said we should not transplant. And this kid remains in remission close to 2 years. So with that, I go to one slide about what is the immunological intervention in leukemia and how that has changed the equation of transplant. So immuno-oncology, you know, is rapidly evolving. So you consider stem cell transplant as basically high-dose chemotherapy plus minus radiotherapy with an immunotherapy, because you're using the donor's immune system to provide graft versus leukemia effect, which will keep the leukemia under control, right? Where does blinatumomab, things like BiTE antibodies, fit into this? So blinatumomab currently, as you know from the Rialto study, that most people are using as a bridge to transplant, and then putting patients into deep remission. But will that put patient in remission that they don't need a transplant? So that's something which future trials will show. And then comes the CAR T cells, which is a new thing, a new kid on the block, and 50% of CAR T cell patients actually on a long-term remission. So introduction of CAR T cells upfront in high-risk ALL groups, probably 50% of them will be in long-term remission. So can you avoid transplant in post-CAR T? So these are the questions which need to be answered, and probably we can if you select patients carefully. The best leukemia treatment outcomes are probably Franco Locatelli's TCR alpha beta and B cell depleted haploidentical transplant, which shows about 70% long-term survival. And what is important, that the sibling, the donor choice did not matter. And if it's a TBI-based transplant, probably a haplo group has equivalent results of about 70% long-term survival. And it's a graft, GVHD, and relapse-free survival. So concluding my talk, just one summary slide is the take-home messages. Is the transplant indications are always changing. What was a transplant indication yesterday is actually may not be a transplant indication today. So it have to be kept updated. And better molecular genetics and response assessment gives us a better risk stratification. So we now know which patient actually does require a transplant and may benefit from transplant. And the risk benefit has to justify a decision for transplant. So if you have a patient who has a 50% rough estimation of a long-term survival just with chemotherapy, then you may do a transplant and the transplant best outcomes are about 70%. So you may increase the 50% to 70%, but this has to come at the cost of the financial cost and the burden of stem cell transplant, and we have to take into account the long-term side effects as well. Transplant center experience is absolutely crucial. The next speaker, Dr. Revati Raj, has done 1,000 transplants, so her experience will be much more than mine. So that's something is very, very important to take into account. Transplant literature, we don't have much evidence-based literature, so more trials like the forum trials are absolutely necessary to come up with very good evidence. And always phone a friend or email a friend, and we always discuss each transplant patient into details and find out the recent literature. So I'll conclude by saying, actually, it's very important to know when not to transplant, and you really have to justify your transplant decision regarding what is it really going to benefit the patient. Is it really worth taking the trouble of doing the transplant and taking all the long-term side effects and everything? With that, I will conclude my talk, my acknowledgement to my colleagues from KK Hospital, Professor Tana Moy, Professor Wing Leong, who was with us. He's still a visiting consultant. Dr. Chan Mayok, Sho Shuyen, Joyce Lam, Enrica Tan, Professor Dayar, Michaela Singh, and Dr. Mia. So, and I'm happy to take any questions.